Good morning and good afternoon to everyone participating in this venue today. I've been told the count is 66, and that's awesome. My name is Bruce Wright, and I have CLL. I was diagnosed in 2009. I went through 5 years of watch and wait, or as you also call it, worry, and received my first treatment in 2014 into early 2015 with a monoclonal antibody known as Gazyva or obinutuzumab. Put me into a remission, and I'm starting to come out of that now and seeing my doctor every 6 months still. We're here today to learn a lot from a very smart doctor who's our friend. As you know, hematologists are friends with us for the rest of our lives as we put up with this disease. I learned about it through the VA system as I am a Vietnam vet, and I also had another form of cancer, a comorbidity, so it was a double bang. It was hard to drive my Harley Davidson home in the LA going home traffic and not crashing, thinking about the big C. But here it is, 2020, and I'm still here, thanks to wonderful new medicine, one family of medicines that the doctor is going to talk about today. In addition to being a patient co-facilitator of the home support group for all of CLL Society, I oversee 10 other support groups throughout the United States. I'm also a patient advisor to the board for CLL Society. My story is in the second quarter of 2018 of my journey with CLL and going through the VA system. It's an arduous system, and when I finished that, I decided to pay it forward by making sure that every patient who is a veteran gets the benefits in plural that they've earned for serving their country. To date, I have helped 73 patients get what they righteously earned. It's all pro bono. My happiness and success and reward is just that they got it. And additionally, I have been added to a national organization called SWOG. It's an acronym for Southwest Oncology Group, which is now a nationwide organization that's affiliated with National Cancer Institute and clinical trial testing. And I'm a community advocate for military veterans and helping them go through this process. We have 3 polling questions we'd like to ask you. They are anonymous, no names are assigned, but it answers the questions. The first one of which is called, which of the following best describes your understanding of your treatment options for CLL? Of the 5 questions, pick which best fits you. Okay, let's go on to question number 2. How confident are you in having a discussion about BTK inhibitor treatment for CLL with your healthcare provider? And the third question we have for you, have you and your clinician had a discussion about BTK inhibitors? Okay, that finishes the 3 questions. Thank you for your participation. We now are going to start our program, and I just want to let you know our goal is to help you, the patient, and your caregiver, because caregivers we treat equally. We're on the same footing. You get the best care when you have a caregiver, and you're becoming even better and smarter patients. Therefore, you'll get smarter care. We want you to learn from this webinar, and you'll be able to ask informed questions, have more informed questions for your clinicians, and in regard to the treatment options that you're considering that are available for your particular CLL profile. We welcome and encourage you to ask me or the doctor any questions you may have. You can type in your questions into the question box on your control panel, and we will make sure that they are answered. Okay, it's now, I have the distinct pleasure of introducing to you Dr. Venugopal, the Director of Hematology at Rush University in Chicago. He will put on a presentation, and you can ask the questions during the presentation, and once it's concluded, we'll answer them for you. Thank you. Doctor, it's all yours.
Thank you, Bruce. Thank you for that kind introduction, and thanks to Kim and Bruce for organizing this program. I hope you can hear me well, Bruce. Very good, thank you. I really wanted to appreciate what Bruce is doing here, and to take a minute for that, because I have been treating patients with CLL over the last probably 40 plus years. And one of the things I have seen in patients with CLL and lymphoma, which is my area, is many of them, do try to give something back. So in other words, they try to help other patients who have been newly diagnosed and who are going through this. Because when you are newly diagnosed, when you are initially told about the diagnosis of a cancer and chemotherapy, you can imagine how distressing it would be. And even if you spend hours reading about and researching, looking at the results and talking to your doctor, 5 or 10 minutes time with somebody who has gone through the same treatment for a same diagnosis makes a huge difference. And that's what Bruce is doing by being patient advocate in the society, CLL Society, as well as the big national SWOG committee. I mean, that's amazing the work you are doing. Anyway, with that introduction, what I'm going to do is over the next 30 minutes, I will first talk about CLL, briefly about what is CLL, how do we diagnose, what are the factors that decide prognosis, when should we think about starting treatment, things like that, simple things, which I think this audience seemed to be very well informed based on the 3 responses I saw for the poll questions. And then the remaining part of the talk, I will focus on the new treatment options, particularly the topic what says here, BTK inhibitors, which has revolutionized the way we treat CLL in this era. So with that introduction, let me start the slides. So chronic lymphatic leukemia or chronic lymphocytic leukemia, as you know, is the commonest leukemia in the Western world. And it is more common in older individuals, even though I have patients now up to 22 years diagnosed with CLL, but it is more common in older patients, 7th decade of life. And majority of patients are asymptomatic at diagnosis. And you can take Bruce as an example. He told you he was diagnosed in 2009, and he didn't need treatment until 5-6 years later. And of course, the median survival depends on a variety of factors. The RAI classification is based on what Kanti Rai put together decades back, but we have also much more prognostic factors, which I'll talk about later, which can refine these numbers even better. And CLL impacts, of course, survival of patients over 75 years. As you can see, it clearly impacts them because it does. The younger patients, their survival is impacted if you compare with the expected survival and the life expectancy in the United States. This is the statistics from what we call as SEER data from the National Cancer Institute. What it shows is in the year 2000, you are expecting to diagnose new cases, 21,000 plus new cases of CLL. Okay. And this forms, as you can see, a very small percentage of all cancer cases, but it is a significant number. So two other points I want you to take from this slide. One, if you look at the 5-year survival, more than 86% of patients are alive at 5 years, or in this one, expected to be alive more than 5 years, which clearly tells you, part of the answer to the question, what is my prognosis? The second point I want to take is from this graph. The one in green represents the incidence. As you can see, the rate per 100,000 person. It varies, although it looked like in the last few years, the number of new cases have been coming down. But certainly, if you look at this line, which represents the death rate, the death rate has been declining. It is slow, certainly, but it is steady. That's certainly a good news. And a lot of it has to do with not only the knowledge we have about the disease, the awareness of the patient's part in getting attention early, and of course, the new modalities of taking care of this disease. So how is CLL diagnosed? Again, from the polling question answers, I realized that many of you have a very good knowledge of the disease and treatment options, so I will go very quickly. CLL is diagnosed most of the time when the primary physician who sees the patient for a routine yearly physical, notice that the WBC or the white blood cell count is higher than normal. Usually the physician will say, well, come back in a month or two, we will check it again, because the patient doesn't have any other symptoms or any other concerns. So the patient comes back, the white cell count is still elevated, and when the physician looks into the type of white cells, it is mostly lymphocytes. That's when either they will give you a course of antibiotics because white cell can be increased in infection, or some of them might say, I think it's a good idea to see a blood specialist or hematologist. And what does the hematologist do? He will talk to you, he or she will talk to you first and examine you, physical exam, and then do some blood work. And one of the things he does is take a blood smear, make a smear in a glass slide and look under the microscope. And what do you see in a patient with CLL? This is what you see. What this shows is, these are what we call as the red blood cells. And these small dots are the platelets. But these larger cells here are the lymphocytes. So you can see majority of the white blood cell are almost entirely lymphocytes. So when you see lymphocytes increased, you worry about CLL or types of lymphoma where it can present like leukemic phase. But remember, lymphocytes can be increased in diseases which are not cancer also. For example, in children, whooping cough causes significant increase in lymphocytes. So we need to find out if these lymphocytes are healthy lymphocytes, just reactive, or cancer cells. So the test that is done is called flow cytometry, taking a sample of the blood, running it through a machine with certain antibodies and laser beams. And that is what typically confirms the diagnosis of CLL. It can tell you if it is a CLL or is it another type of cancer. So that is how CLL is usually diagnosed. And now the question comes, hey, what is my prognosis? Prognosis can be a word used in many different occasions in terms of how long am I going to live? What are my complications going to be? Now, as I mentioned before, prognosis depends on many factors, but I'll focus on some of the new things. In 2020, when you're diagnosed with CLL, you should be asking your doctor some questions about what are my prognostic factors. And here is a list of some of them which are routinely tested in most patients. You heard about probably CD38 expression. This is the expression of the protein on the surface of the leukemia cells. ZAP70. This is a mutation called IGHV, or immunoglobulin heavy chain variant mutation. This is another protein in the blood, serum beta-2 microglobulin. This test, FISH, is standing for fluorescent in situ hybridization or cytogenetics. These are tests to find out if you have any chromosome abnormalities, as you mentioned here. And of course, look at gene mutations. So to make it simple, these are some of the terms I would like you to remember to ask your doctor if you haven't already discussed. What is my chromosome? Is it normal? Do I have any abnormal chromosomes? Same thing with FISH and PCR, or polymerase chain reaction. Have you done my mutation analysis, which nowadays we do something called NGS, or next generation sequencing, where you look at many hundreds of genes and see if there is any evidence of an early change in the gene that may be representing a prognostic factor. So I think these are some of the terms that will be useful in your discussion with your blood doctor if it is not already discussed. Well, what is the importance of these? Well, if you have the results of the FISH, for example, if you know your FISH results, if you have a 17p deletion, that imparts adverse prognosis. For example, this is the proportion of patients surviving from 100% all the way down to 0. You can see that this is the months during which the progression occurs. Patients who have 17p deletion has the worst prognosis. They come with disease very quickly and succumb to the disease quickly, whereas patients who have normal chromosomes or 13q deletion, they do very well. So knowing your chromosome abnormality, which is also measured as FISH, will be extremely useful in determining a prognostic factor or prognosis. IGHV mutation is important. Patients who have the mutation do very well compared to patients who don't have the mutation. The next question will be, what are my indications for starting treatment? As I mentioned before, just like the example of Bruce, most patients don't get treatment recommendation at diagnosis. We watch them for a period of time, and when they need treatment, we recommend treatment based on many factors. And what's the common indication for treatment? Well, if they have symptoms referable to CLL, like lymphoma, if the patient develops symptoms that are attributable to the disease, like fever, weight loss, night sweats, that's an indication. If there is evidence that your bone marrow is failing, in other words, your hemoglobin is going down, you are becoming more and more anemic, you're becoming thrombocytopenic, or your platelet count keeps going down, putting you at a high risk for bleeding. Or your spleen is enlarging. Sometimes it can enlarge to an extent causing symptoms like early satiety or abdominal discomfort. Or your lymph nodes in the neck, for example, if it becomes too much. One of my patients couldn't even put the collar button because it was too big. And those are, again, indication for treatment. And of course, if your counts go up very fast, there are definitions for how fast. That's another indication. So these are clearly indication for treatment. Once you decided that, yes, you have an indication for treatment, as I said, please remember, observation is appropriate in the absence of indication for treatment. That's a message you should take from the slide. If treatment is indicated, the first line treatment options are chemotherapy, which used to be the most common method, but nowadays we rarely use chemotherapy. And I will tell you one example where you may use it, but that's a very small number of patients where you may still use it. You use these proteins called monoclonal antibodies, rituxan, you heard about Gazyva. Then combinations of chemotherapy and monoclonal antibodies. And of course, the newer drugs, ibrutinib, acalabrutinib, which are the BTK inhibitors we'll be talking about, and another newer drug called venetoclax. Of course, in all cases, you should ask for any clinical trials that are available, which may be using these drugs in combination or drugs which are even newer to this but not FDA approved. Now, this is one situation where a chemotherapy may be still useful. This chemotherapy called FCR is given every month for 6 cycles, and that is it. Patients who received 6 cycles of this, when they have this mutation, the one I told you before, IGHV mutation, they do very well. So in other words, after 10 to 15 years, about 60% of those patients still don't have evidence of disease. And so this proportion of patients, certainly this is an option, even though, as I will show you later on, even in this group of patients, the new drugs are working much better with much less side effects. So let us look at the new agents in CLL and the timeline. So if you look at the last almost 10 years, so many new drugs. You heard about Gazyva, which is truly called obinutuzumab. It is FDA approved now. You can use it with ibrutinib or Imbruvica, or the older drug called chlorambucil, which is a pill. Idelalisib is one of the drugs called PI3 kinase inhibitor that can be used with rituximab in patients who have relapsed disease, not in the upfront. Ibrutinib, as I just mentioned, is the BTK inhibitor. We'll be talking more about it, and the newer BTK inhibitor, acalabrutinib. Venetoclax is the BCL2 inhibitor, and duvelisib is also an oral agent, which is a newer form of this drug, the PI3 kinase inhibitor. So these two are in the same class. To show you the mechanism of action of these novel agents, which, as you know, are targeted, right? These agents target the cancer cell, unlike the chemotherapy, which can affect the normal healthy cell also, which is what causes most of the side effects, including loss of hair and drop in your blood counts, which typically these novel agents don't do it because they only target and kill the cancer cell. So if this is the cancer cell and this is the nucleus, you can see there are many terms here. These are all proteins on the surface of the cancer cell. And these proteins are targets for certain antibodies, like, for example, rituximab or Gazyva targets the protein called CD20. They come, bind to it, and then kill the cell by a variety of mechanisms, because the binding of the antibody to this antigen starts a lot of series of reactions that kills the cell. It also brings the natural killer cells in the body, the so-called T cells. And that's why this BiTE, that is the bispecific antibody, which is neat. It has 2 arms. It binds to the CD20, but the other arm brings the T cells to the site so that it enhances the killing of the cancer cell. It's a beautiful mechanism. So like that, there are other agents. This is the BTK inhibitor, which works through the B cell receptors. And of course, you have many others, including CAR-T, which I will mention later on, the PI3 kinase inhibitor, and the so-called PD-1 inhibitors, or so-called checkpoint inhibitors, are also active agents in B-cell malignancy. And as I said, BTK is a central common pathway where these drugs work. The activity, passes through the BTK, which increases the survival and proliferation of the cancer cell, and that is what is inhibited when these drugs block the BTK. So this slide shows you the names of the three BTK inhibitor. BTK stands for Bruton tyrosine kinase. That's the pathway that is inhibited. So these are the three FDA approved drugs which comes under this class. There is a variety of others which are not yet FDA approved. Ibrutinib or Imbruvica was the first one that was approved, and it is FDA approved for CLL alone or in combination with the monoclonal antibodies. This drug is also FDA approved for certain other lymphomas. We call it mantle cell lymphoma, Waldenstrom's, marginal zone lymphoma, and also for a disease in patients with transplant. It's not a cancer by itself. This is a graft versus host disease where it is approved. Acalabrutinib is approved for CLL and small lymphocytic lymphoma or SLL. It's also approved for mantle cell lymphoma when it is relapsed. Now, the latest FDA-approved BTK inhibitor is zanubrutinib. Now, zanubrutinib is not at this point FDA-approved for CLL. It is only FDA-approved for relapsed mantle cell lymphoma. Now, this tells you how it is administered. All of them are oral agents. This is taken once a day, this is taken twice a day, and this one has FDA label for once a day as well as twice a day. This mentions some of the key toxicities. Ibrutinib is associated with bleeding and atrial fibrillation or irregularity of the heart, and of course some gastrointestinal symptoms like diarrhea and also increase in infection. And acalabrutinib is a common side effect to have some GI symptoms and diarrhea. And Zanu also has similar GI side effects. So this is one of the longest trial data we have. For example, these are patients who took just ibrutinib or Imbruvica alone. And after 8 years follow-up, you can see that they remain without progression. So PFS stands for progression-free survival, which means how long the patient remains on the drug without the disease coming back. As you can see, majority of patients, 83% at 7 years, have no evidence of progression. And as you can see, 84% of them are alive also at that time period, 7 years. So it clearly indicates by taking a pill, if you can keep them without disease coming back and with good quality of life, you can imagine the achievement that this new drug has made over what we had before, that is chemotherapy. This is a randomized trial, the phase 3. Phase 3 means you compare it with what is considered as standard of care. So these are patients who received ibrutinib, how they did without the disease coming back, compared to patients who received what is considered standard of care in the past, not now. This is chlorambucil, which is a pill we used in the past, but it's a chemotherapy pill. Unlike this is a chemotherapy and very, rarely, if at all, used nowadays. But FDA used it or asked for it as the comparison because that was the old comparison or standard of care. And you can clearly see the drug has made a significant impact on the disease control in these patients. Now, in the last 1 year, there has been 3 major studies which showed, each one of them showed that these new agents, when you compare it head to head with the chemotherapy we used in the past, were superior. And that's what I'm going to show you in the next few slides. Okay, so 3 major studies in 2019, which have influenced the first-line treatment of CLL. So this one combined Gazyva or obinutuzumab with Imbruvica and compared it with Gazyva with chlorambucil, the oral chemo pill I talked about. Okay, so compared to the chemo combination, you can see that there's a significant proportion of patients, almost 80% of them, after 2.5 months, remain without evidence of progression. And this benefit was seen even in the high-risk patients. High risk means they have the higher risk chromosomes and mutational status. So clearly, this is the winner, as you can see. So the first non-chemotherapy combination was approved by the FDA in January of 2019 based on this study and this data. The next trial compared a chemotherapy regimen. This is probably one of the most intense chemotherapy we used in CLL in the past. FCR, combination of 3 drugs. And these 2 are chemotherapy, and this is the antibody rituximab. So this combination of chemo antibody was compared with ibrutinib and rituximab. Okay. And what was the outcome? You can see here, patients who received this combination, ibrutinib and rituximab, did very well. As you can see from these numbers indicate that the difference was statistically highly significant. So more patients who received the novel agent did continue to live without progression of disease compared to the chemotherapy combination. And even the survival, even the risk, the chance of them surviving was much higher in patients who received a novel combination compared to patients who received chemo. So ibrutinib plus rituximab leads to a better disease control and survival compared to the standard FCR chemotherapy. That was conclusion from the study. The next is comparing a chemotherapy, another chemotherapy which is very commonly used, which is better tolerated than the FCR, bendamustine and rituximab. This was compared to ibrutinib or ibrutinib with rituximab. Again, showing that when you have ibrutinib, they do much better compared to patients who received chemotherapy. The message was clear. So ibrutinib with rituximab lead to better disease control compared to bendamustine and rituximab. So what about patients who have relapsed, that the disease came back after the first treatment? Again, you have chemotherapy, again, less attractive option, but combination of monoclonal antibody. There is another antibody which many of you may not have heard about, Campath. It is still around, but we used in the past, even though it's a monoclonal antibody, it's not a chemo, but it has significant side effects in terms of infusion reaction as well as infection. That's why it is not very often used, particularly because of the availability of better drugs. Ibrutinib, acalabrutinib, and venetoclax and clinical trials are appropriate options when the disease comes back. So ibrutinib again has been shown to be superior compared to one of the monoclonal antibodies in patients with relapsed CLL. You can see the difference here, significant difference in the number of patients who remain without progression. And even when it is administered as a single agent without combination, acalabrutinib did very well. In majority of the patients, 94% of them had response. And here is a study where they compared acalabrutinib, the newer one, with chemotherapy combination or one of those other agents, the PI3 kinase inhibitor. Again, showing that acalabrutinib as single agent did extremely well and significantly superior compared to the competing drugs. Now, is there a head-to-head study between these two BTK inhibitors, ibrutinib and acalabrutinib? Well, it's going on. We don't have the results at this time. There's also a head-to-head study between ibrutinib and the newer one, the most recently approved one, zanubrutinib. Again, that is going on. And obviously, results of these we will be hearing in the near future that will help us decide which one would be a better choice. Because right now we are comparing different studies rather than one study where these agents were compared. So if you want to summarize the BTK inhibitors in the setting of relapse CLL in one slide, these are the two agents we are talking about which are FDA approved for this indication. Again, as I mentioned, these are different studies. So it is not, it's almost like comparing apples and oranges, but that is all what we have now there before we get the randomized studies, which will take some time. But if you compare the available study results, you can see that both ibrutinib and acalabrutinib are significantly superior to the current standard of care or even some of the newer drugs which are already in the market for this indication. Venetoclax is the other group of drug. It's not a BTK inhibitor. This is a BCL2 inhibitor. That's the name of the family of the disease. It inhibits a protein called BCL2, which is expressed very high in certain kinds of lymphomas and CLL. And this protein is a driver of the tumor cells. So if you inhibit it, it will slow down and put the CLL into remission. And that's what is happening. You can see here, this is an oral agent. So just taking this pill alone, 80% of patients, if you see all of them, responded, with about 20% of them going into complete remission. And even in patients with the very bad chromosome abnormality 17p, majority of them responded very well. So it's a very active agent as a single agent. Obviously, the question is then, how about combination with monoclonal antibody? When you combine it monoclonal antibody in the setting of relapse CLL, you can see again, compared to bendamustine rituximab, which is a standard chemo combination, venetoclax and rituximab did significantly better in terms of keeping the disease under control without progression. So we have, as you can see here, very good data now showing that not only this is very active, but also the remissions are durable. And venetoclax plus rituximab leads to better disease control compared to bendamustine or rituximab, and it's an FDA-approved option too. So that takes me to the last slide of this presentation. So over the last, looks like 25, 30 minutes, what I did was to convey the message that number one, in CLL, we have made a lot of advances in terms of understanding the disease, understanding the prognostic factors, and also making informed decisions about the treatment based on some of the prognostic factors. And that's very important. The prognostic factors I showed you are not only important in determining the risk of progression, how often patients should be watched, but also in selecting the medications appropriate for the patient. Importance of personalized therapy based on the patient characteristics as well as the disease characteristics, some of which we went through. And I emphasize the fact that the majority of patients with CLL now who needs treatment are treated with the non-chemotherapy options in the first line as well as subsequent therapies. And as always, particularly as someone who has been doing it for the last several decades, I will always encourage participation in clinical trial. We have these very good medications in the market now, but how did they come into the market? Because of volunteering by patients, hundreds and thousands of patients who volunteered in clinical trials. Of course, many of them did get the benefit of getting these drugs much before it was FDA approved, but they also helped bring these drugs to the market so that many other patients got its benefit. So I would encourage that. Please participate. Please ask your doctor if you need a treatment. If the doctor is talking to you about treatment, ask them if they have any clinical trials open or if there are other centers where you can go and look at clinical trials. With that, I will stop my discussion and I'll be happy to answer any questions. Bruce, back to you.
Thank you, Doctor. As usual, I've had this disease since 2009, and yet today I still learned something new. So I thank you, doctor, for putting the information together. It's direct,
Well,
it's succinct, and it's educational. So we're going to open the questions in just a minute, but I want to call everyone's attention down at the bottom of your display, a little bubble that says chat. If you open that, you will see something from her Jersey girl. That's my nickname for her, from Plexus. We hope you are enjoying the presentation. If you would like a copy of the slide presentation, you can email us at info@plexuscom.com. Reference today's webinar. So if you open up that chat box, there's the email link. Just send a note, say you were a participant in today's webinar, and we'll be happy to forward to you a copy of the doctor's presentation. I'm already on the list for that. So that's there to you anytime you want to take a look at it. Now in the bubble next to it on the left-hand side, we have 3 questions in the Q&A. So we'll take and open that puppy up. And the first question comes to us: what does 53% MRD positive mean after 3 years on ibrutinib? ALC is 4.2, no other symptoms. Over to you, doctor.
I think what I heard is that this individual is on a BTK inhibitor for 3 years, and the ALC, which usually stands for absolute lymphocyte count, the number of lymphocytes in your blood, is, I think I heard 4.2. And also I was told that the MRD in this context, it has many definitions, but in this context, MRD stands for minimal residual disease. That means when you're diagnosed with CLL, you have evidence of CLL in the blood. You know, if you do a bone marrow, it is there, lymph nodes, so there is a lot of evidence. But once you treat it, all the evidence goes away. But sometimes you can have very minimal evidence, which can be picked up by flow cytometry or chromosomes or PCR. That may be the only evidence. So if that is the only evidence, that is what is called MRD positive. If MRD is negative, those patients usually have the longest time without the disease coming back. So if I understand the question correctly, if you have CLL and you're on a BTK inhibitor and your ALC and MRD numbers are what you just said, I think it is very appropriate at this point. You know, certainly in terms of response, you have responded extremely well. You do have a choice, you know, to stop the treatment and watch closely, or you can continue if you're tolerating it extremely well, because right now, we don't know what exactly is the cutoff in MRD that we should utilize to recommend stopping of the drug. We already made advances in the other type of leukemia called chronic myeloid leukemia, because a drug like BTK inhibitor was approved there 20 plus years back. So we have experience now, we know what is the level of MRD where we can stop it, but we don't have that information in CLL. So I think my suggestion would be to sit down with your doctor, who will know much more about your course of disease and prognostic factors before you make a decision about stopping versus continuing the drug.
Bruce, you have to unmute yourself. Also, Dr. Venugopal, I just want to draw your attention to the Q&A box. If it helps to also read the question, there you can pull up the Q&A box there at the bottom.
Mine is okay, got it.
Okay.
Okay,
yeah.
so yeah, Bruce, do you want me to read the next question?
Sure, go ahead, because that's a big question and you're the guy to answer it.
Okay, well, I'll give it a try. Okay, so what it says is, can Dr. Venugopal, thanks for spelling my name correctly, it's not easy, explain a little more about the impact of CLL, impact CLL has on B cells? Does it affect B cells in the body or only progressively affect the B cells? For diseased B cells, what impact does CLL have on the antibodies derived from them? How does CLL impact B cells' response to cytokines lead by helper T cells? Does CLL impact health of T cells? Very good question. Okay, so I'll try to put the answer together so that the other individuals in the program also follows and take home something. So the question here is, how does the disease CLL affect the other cells, including the normal healthy B cells, right? I mean, everybody has B lymphocytes and T lymphocytes, and the typical CLL is a disease or a cancer that arises from the B lymphocytes. So the question is, how does it affect the normal healthy B cells? Well, in CLL, majority of the cells, as you saw, was, of course, will be leukemia cells, but there will still be a healthy population, a population of healthy B cells, which still makes the proteins, the immunoglobulins that fight infection. So that the measure and the best way to find that is to check your immunoglobulins in the blood. If your immunoglobulins in the blood, so-called IgG, IgM, IgA, those are the proteins that fight infection normally. If they are normal, that means you have a good population, a good healthy population of B cells that are making it. So that is one. And if they are low, that means the CLL is really inhibiting those B cells also. Now, most of the time when you start a treatment with a monoclonal antibody, as you know, the monoclonal antibody targets the CD20 protein, and CD20 protein is on the surface of the B cells, whether it is healthy or CLL cells. That means the monoclonal antibody wipes out the CLL cells as well as the healthy cells. So majority of patients who are on a monoclonal antibody targeting CD20 will have low immunoglobulin levels. And in some patients where the low immunoglobulin levels lead on to multiple recurrent infections, pneumonia, we can replace the immunoglobulin. I'm sure some of you are familiar with that. Every month or every 3 weeks, you come to the clinic and get an infusion of so-called IVIG, which is the immunoglobulin protein. And the last question there, does it impact the health of T cells? Very unlikely the CLL per se impacts it, other than if it can, drive them out. If the marrow is full of B cells, physically the T cells may not survive there. Sorry, it was a long answer, but the question had multiple, subtypes. That's the reason I had to go on. Okay, let me see if I can read the questions below that. I just started VEN, which is venetoclax, and G, which is Gazyva or obinutuzumab, as first-line treatment. You only mentioned Ven and rituximab. No reason. You're absolutely correct. I mentioned that as a typical anti-CD20 monoclonal antibody. As you know, rituximab has been around for 20 plus years, whereas Gazyva is more new. But clearly, if I was asked to prescribe a monoclonal antibody plus venetoclax combination, I will prescribe Ven plus G. Next, have you seen evidence of cardiac issues other than AFib, arterial spasm with calquence? Okay, so calquence is the second drug I mentioned in the BTK pathway, that is acalabrutinib. And BTK inhibitors, primarily ibrutinib, can cause atrial fibrillation, which the incidence is much less with calquence, as you know. And the answer, the question was, have you seen other arterial problems? I personally haven't, but they have been reported. Obviously, it is very rare. What about being on acalabrutinib and neutrophils and WBC stay low? Yes, It is not a common side effect. It is rare, but yes, you can have a slight reduction in the neutrophils. That is very common. But as long as the neutrophils stay above 1,000, I really don't worry about it unless the patient already has a history of repeated infection, where I will be more careful. Do you have any thoughts on treatment with BTK like ibrutinib versus Ven plus G for the first line treatment? Yeah, that's always a very good question. In the absence of a direct comparison data, it's very difficult for me to answer that question, because if you just look at the efficacy with what we know with the short-term follow-up on these cases, it is certainly both seem to be very effective. How do we then try to save one over the other? Well, one is BTK inhibitor, as you know, has a much longer track record. The first slide I showed you was 8 years already, the data is there, and we all have experienced much more than that with BTK inhibitor. So that is one advantage on its part. On the other hand, the bleeding is a concern, especially if somebody is on a blood thinner. Okay, if somebody is taking warfarin or one of those newer ones like, Eliquis or, rivaroxaban or Xarelto, I try to stay away from the ibrutinib because of the concern for BTK inhibitor causing bleeding. But remember, that is not a contraindication even based on the FDA label. I still have patients on blood thinners and BTK inhibitor, but those are patients where I felt that BTK is the best option for that patient. And the next question is, if you reach MRD negativity, will 11q SFP31 and mutation status change? Good question. Well, it depends on where these abnormalities are, because MRD negativity means the detectable number of cancer cells, leukemia cells, are gone. So if these abnormalities like 11q and the other molecular abnormalities and the mutation, IGVH mutation, if they are located on the same cell, which is what typically happens, then they should be gone too. And coming down, one more question I see is, how do a patient's prognostic factors that you mentioned affect how you decide which targeted treatment to use? That's a very good question. Yeah, I think the one example I showed was about the IGVH mutation. I told you that, yes, if the patient has IGVH mutation, they do have an option for chemotherapy where you take 6 cycles of FCR, and there is at least 60% chance that after 50 years, they will still don't have any evidence of disease. But then, that the new agents also work very well. Only thing is, we don't have the kind of long-term data with those. So that's why we don't know if the efficacy seen by the new agents will last that long. We don't know that. We do know that chemotherapy like FCR comes with side effects. Short-term, infectious complications because of the significant blood count lowering, and long-term, including long-term side effects like acute leukemia, as well as bone marrow damage to stem cells, MDS. Those are all complications known with that kind of chemotherapy. So the patient will have to make a decision whether I want to just take 6 cycles of treatment and get a chance of 60% without evidence of disease in 15 years and risk myself to the things I just mentioned, or should I just start one of these new agents, which are much easier, take a pill and go and get some infusions of antibody, which is not with any side effects of chemotherapy, but they are known that after 5 years, 10 years, 15 years, what is the outcome? I don't know that. So I think that's a decision they have to make. I see there are some more questions. I had to pull it down. Okay. My doctor is recommending venetoclax and being hospitalized to start. I'm concerned with COVID-19. What are your thoughts? So some patients with the CLL needs to be hospitalized when you start the pill, even though it's a pill, when you start venetoclax, because they can, some patients can suddenly break down the cancer cells, and the things that come out of the cancer cell, like potassium, uric acid, those can cause significant kidney and heart damage. That's the reason why they have to come in. Not everybody, only very selected patients, and there is a very strict criteria. And if you fall into the high risk for tumor lysis syndrome, then we typically bring the patient into the hospital for a day or two, and majority of them don't have any problems. I think the question here is concerned with COVID-19. Well, in my hospital, I always feel that the hospital is much, much safer than going to a grocery store, because they are very strict about, starting from the place you walk into the hospital. They check your temperature. There's a variety of things they do before they get you to the hospital. So I think if your doctor, decided, number one, you need treatment, and number two, venetoclax is the best option for you, and number three, you are at high risk for tumor lysis, then I would certainly, go ahead and, get treatment started, as long as, that they are following the standard guidelines for preventing COVID infection. Next one is for your patients who received venetoclax, which is same as venetoclax. Do you really stop their treatment after 1 year? What kind of side effects you see? Yeah. So the first part, do you really stop after 1 year? Probably not. I said probably because it all depends on how much is the response. Some patients, even after 1 or 2 cycles, they have dramatic response. In those patients, after 1 year, if they are negative at the MRD level, yes, I would be happy to stop and watch the patient. Side effects with venetoclax, the major part, the thing is the tumor lysis syndrome we worry about, and now there is very effective way to prevent that. Would you recommend a BTK inhibitor after REPOC if the MRD is negative? I think I'm assuming that this person may have a transformed CLL, because typically for CLL, chronic lymphocytic leukemia, we don't give this REPOC, because that's a regimen used for aggressive lymphoma. As you all know, rarely CLL can transform to aggressive lymphoma where it may be used. And if that is the case, okay, if you have transformed lymphoma, then after chemotherapy, if your MRD is positive, that's exactly what I will do. I will keep them on one of the, inhibitors, either BTK or venetoclax. Finally, are there any challenges for a patient going on BID dosing versus once a day? Challenges other than the fact that, compliance, because, we always feel that the more number of times you have to take the medication in a day, the less is the compliance, because you are likely to miss dose or forget. Other than that, scientifically, pharmacodynamically, I don't see any reason for a change.
Dr. Venugopal, we do have someone named Amy had raised her hand to ask a question. So Amy, if you still have the question, I'm going to go ahead and allow you to unmute your microphone so you can ask the question. And then one other final question, Dr. Venugopal, someone had chatted into the chat box. I started on acalabrutinib end of May 2020. No significant side effects, except I am getting mouth blood blisters. Is this due to acalabrutinib?
Yeah, I think it is very difficult for me to say that when you say blood blisters, because blood blisters can be due to many things. It is true that just like ibrutinib, acalabrutinib can be associated with bleeding, but most of the bleeding, what we call as grade 1, 2, which is very low grade, small spots, things like that. So if you have blood spots, I think it may be a good idea to have your doctor check it, because, for example, if your platelet count goes too low, you can have blood blisters. So I think that needs an examination before we say what is causing it and what is the best way to manage it.
Okay, and then Amy, are you on? Did you have a question that you wanted to ask Dr. Venugopal before we end today's program?
I hit the hand by mistake. I already asked.
Okay.
Q&A.
Okay, that's what I
Thank
was
you.
wondering. All right.
There's one more question that just came in from Stacy, if you want to read that one at the bottom of the Q&A.
Okay, we'll take one more question, Dr. Venugopal, before we end.
Yeah, you mentioned there is an effective way to avoid tumor lysis syndrome. Yes, absolutely. Tumor lysis, again, is breaking up the cells quickly when you start treatment in CLL. And the best ways to avoid, of course, is to take medications like allopurinol. Allopurinol is a medication to prevent kidney damage from uric acid, which is one thing that goes up in the blood when you have tumor lysis. Also, drink plenty of water. And of course, if you are at high risk, as I said, you need admission to the hospital, and they will give you IV fluids and allopurinol and monitor your kidney function, potassium, uric acid very closely.
Before we turn the program over to Bruce to close it out, I just want to thank Dr. Venugopal and Bruce Wright on behalf of Plexus Communications, Rush University, and the CLL Society. We're so grateful that you both took time out of your busy schedules today to give this patient and caretaker webinar, and we truly appreciate that. And thank you to everyone who has participated. There is a brief survey if you're able to stay on at the end of the webinar, but we will also be emailing that to you, and we encourage you to complete that survey. It just takes a couple seconds. We also want to thank AstraZeneca, who provided an educational grant so that we could make this program possible. At this time, I'm going to turn the program over to Bruce Wright so that he can go ahead and close us out.
Thank you, Kimberly. We appreciate everyone's attending today. We're sending you away a little smarter on the disease that we all share. We didn't plan on it, but we have that wonderful acronym for the rest of our lives, but we're going to stay ahead of it. I've been involved with it for 11 years. The leader of our support group, Terry Evans, has had it over 20 years and several failed protocols, and he plays golf a lot today, okay? I term I use when I talk with my fellow CLLers is own your disease. Learn everything you can about it. Learn your numbers. The numbers are important because that affects your treatment. My numbers are 13q deleted, I'm mutated, I'm CD38 negative, and I'm ZAP70 negative. I'm a fortunate one in a corner, but you know those, and with those you can dialogue with your doctor to learn the extent of your disease and what is the best medicine for you to use. And we now have a renaissance with the BTK inhibitor family that got us over the hump and away from chemotherapy, and we're forever grateful for that. Again, thank you for attending, and we'll be happy to stay in touch. You can find me at the cllsociety.org. My email is bwright@cllsociety.org. You can email me anytime you'd like. Thank you.